We'll go over some background information on why long-acting reversible contraceptives, and specifically about the need for IUDs. We'll then go over some more specific information with regard to our products. So we'll go through a product overview, some clinical information on the two products, what specifically is a levonorgestrel IUD, and talk about other things that relate to some of the counseling questions that come up, once a patient is considering an IUD and once it's been placed. And finally, we'll end with a hands-on training after you've gotten a chance to see insertion process via video. So why a long-acting reversible contraception? So unfortunately, the unintended pregnancy rate in the United States remains high. The Healthy People goal for 2010 was to decrease the unintended pregnancy rate from 50% to about 44%. That had not been met yet, but there's been recent published literature in the Gutenmacher, if anybody has seen that for the first time in 30 years, we've actually made headway in decreasing unintended pregnancy rates. However, it still remains high. There is a difference in the number or percentage of unintended pregnancies dependent on age range. So you'll see here that the unintended pregnancy rate in the younger age range is higher. So in the women between the ages of 20 and 24 years old, it's about 34%. Approximately half of all U.S. pregnancies are unplanned, and roughly 3 million that amounts to about 3 million pregnancies, and about half of those unplanned pregnancies occur in women that say they're on some sort of birth control. So when considering a contraception option, patients should be counseled on starting with the most effective method of contraception. And this is a tier of efficacy on contraceptives visual that is provided by a number of organizations. In particular, the WHO has a version of this. But anyhow, you'll see here that as effectiveness goes down, user dependence goes up. Right? And so, for example, with implants or IUDs, and of course with permanent sterilization for females and males, those will be the most effective methods of contraception, and those are least dependent on the user or the patient. However, with methods like spermicides, withdrawal, or condoms, those depend a lot on how the patients are using those methods. There are a number of organizations that endorse using long-acting reversible contraception, including ACOG and the CDC. And most recently, the American Academy of Pediatrics also endorsed using long-acting reversible contraceptives in adolescents as a first-line option for contraception. Unfortunately, although we did look at the tiers of efficacy and we saw that, the most effective forms are those that are methods that are least dependent on the user, those are not the forms of contraception that are being used most frequently. And the ones that are being used frequently are those that are dependent on the user, such as you'll see here, for example, an IUD, which is very effective, is used less commonly than a condom. So what are LARCs? What are the methods that are available? This group includes IUDs and implants. And this includes a group of contraceptives that are highly effective with typical use and are less dependent on patient involvement. There are estrogen-free methods that may be considered by women who cannot use a combined hormonal contraceptive. This was a study that was done out in St. Louis, and the primary objective of this study was to provide non-cost contraception to a large number of women in a region and promote the use of LARC. And they looked to remove barriers for access to contraception and provided women with counseling on all methods. And what they found that after counseling was provided on all these methods of birth control, participants chose their contraceptive method that was provided at no cost, and the most frequently chosen was a LARC, was some sort of long-acting reversible contraceptive. So with that, we'll jump into talking about IUDs in specific. So, levonorgestrel IUDs in particular should be considered for women who desire one of the most effective reversible contraceptive methods, who desire a long-term method. So the two methods that Bayer offers, or the two levonorgestrel IUDs that Bayer offers, one is is indicated for 5 years of use, and the other is for 3 years of use, and we'll talk about which is which in just a second. These women are also, do not wish to have a daily or weekly routine when it comes to their contraception, and do not want a postcoital method either. So who are those patients that are not appropriate for levonorgestrel IUD? Of course, women who you suspect of being pregnant or are currently pregnant, women who are known or suspected to have a uterine or cervical neoplasia, reason being is that you have a hormonal contraceptive that you're introducing into a suspicious area, and that area might respond positively to that hormone. This includes, this group of women also include women who have an active pelvic inflammatory disease that's ongoing. These levonorgestrel IUDs should also be used with caution in patients who have certain conditions. For example, patients that have a coagulopathy or taking an anticoagulant. And you might ask yourself, so you've heard that Mirena has been used for women that have heavy menstrual bleeding. And some women that have a coagulopathy might have a heavy menstrual bleeding, right? So why do we say use with caution? So in women that have heavy menstrual bleeding that are put on a Mirena, because that is a secondary indication for Mirena, these women should be monitored very closely. Because yes, they have a coagulopathy, yes, they have heavy menstrual bleeding, but as you'll learn about more in the upcoming slides, in the first 3 to 6 months after an IUD has been placed, there is irregular bleeding, and there can be heavier menstrual bleeding. But after that, the periods become shorter, lighter, and in some cases will stop completely. So in those types of patients, just use caution and monitor them very closely. There are some other considerations to keep in mind as well. And these are really precautions for the class, right, for the progesterone class that are mentioned within our label. But keep in mind that levonorgestrel, the IUDs that we have, their mechanisms of action are localized. And again, we'll talk about that in more detail in just a bit. So let's jump into the clinical overview describing Skyla and Mirena. So Skyla is a levonorgestrel-releasing intrauterine system that contains 13.5 milligrams. It's indicated for the prevention of pregnancy for up to 3 years. It may be used whether or not a woman has had a child. And the Mirena is an IUD that has 52 milligrams of levonorgestrel, and it's indicated for the prevention of pregnancy for up to 5 years, and has a secondary indication for the treatment of menstrual bleeding in women choosing an IUD as their method of contraception. It's recommended for women who have had at least one child. And you'll see this within the label and within the recommendations, because Mirena, for the most part, in the clinical studies, was studied in women that had had at least one child. So what is a levonorgestrel IUD? So we'll go through the properties of each device or insert. So for Mirena, it's about 32 by 32 millimeters. For Skyla, the dimensions are a bit smaller. They're 28 by 30 millimeters. They're both T-bodies, and they both have a drug reservoir that contains the levonorgestrel. Again, for Skyla, it's 13.5, and for Mirena, it's 52. No component of either IUD contains latex. The Skyla has a silver ring at the crux of the T-body, and that's there for differentiation purposes. So if a patient comes in, she has an IUD put in, a lot of times patients don't remember which IUD they got, especially if it's been some years since it's been placed. So if an ultrasound or any other form of imaging is done, the provider knows, okay, they have a Skyla in versus a Mirena in. And because the Skyla has a silver ring on it, we say that Skyla can be safely scanned with MRI only under specific conditions. So it's MRI conditional. There are certain parameters that radiologists can use when a patient has a Skyla in place in order to be able to obtain MRI images for that patient. They just need to be told ahead of time. Is there a recommendation to do routine imaging prior to placing an IUD for a patient? So the answer is, per the instruction for use, per the label, there is no recommendation. And mainly that's because, number one, that wasn't studied that way, and number two, there's really no governing body like that ACOG or any of those folks that give clear direction on, yes, you must do imaging before you do an IUD. There are some providers that choose to do so, but there's no clear guideline that says you must do that. But certainly if you know that your patient has a unicornuate uterus or has some other uterine anomaly, keep that in consideration when counseling for an IUD. So we've gone over the size, the hormone reservoir. We'll go into the initial release rates. So for Mirena, it's about 20 micrograms per day, and for Skyla, it's about 14 micrograms per day. The terminal release rates, so the release rate at the end of the life cycle of the product within the patient, for Mirena, it's about 10 micrograms per day, and Skyla, it's 4 micrograms per day. The diameter of the inserter also differs for each IUD. For the Mirena, it's about 4.4 millimeters, and for Skyla, it's 3.4 millimeters. So now we've talked about the two different IUDs. Remember, Skyla has 13.5 milligrams, and the Mirena has 52. So now we'll talk about their effectiveness. For Skyla, the Pearl index at 1 year was 0.41%, and the cumulative efficacy over a 3-year period was 99.1%. Patients, of course, should be checked 4 to 6 weeks after the insertion, and then yearly after that, once they've had the device placed. Just a little bit about the study design or the clinical trials for the product. So the study was a multi-center, multinational, open-label 3-year trial. It included about 1,400 women, over 15,000 cycles, and as mentioned before, there were about 40% of these women that were nulliparous. The primary efficacy endpoints were the 1-year Pearl index and the cumulative 3-year pregnancy rate that we reviewed in the last slide. For Mirena, the efficacy rate at 1 year was 99.8%, with a cumulative efficacy over 5 years of 99.3%. Again, same with Skyla, patients should be advised to come back after 4 to 6 weeks after insertion just for a follow-up visit. The clinical study for Mirena was included 2 large trials with about approximately 1,200 women, and the bulk of these patients were women who had previously been pregnant. The primary endpoints for this study were a 1-year pregnancy rate and a 5-year cumulative pregnancy rate. So now that we've talked about efficacy in pregnancy, what if pregnancy does occur? IUDs and levonorgestrel IUDs are very effective, as you've seen, at preventing pregnancy. However, if pregnancy does occur, there is a high likelihood that half of those pregnancies that occur with an IUD in place will be ectopic pregnancies. And so if you have a patient that comes in who has had an IUD and a Mirena in for about a year and has developed amenorrhea, because there's a 20% amenorrhea with Mirena at 1 year, and she's complaining of abdominal pain and bleeding, some of the first things to consider are, number one, where's the pregnancy? Because as I mentioned, 50% of those pregnancies will be ectopic. And number two, where's the IUD? Because clearly, if she's gotten pregnant, then the IUD is not, in the appropriate place to be, functioning well. Women should be counseled on the signs of ectopic pregnancy and their associated risk, including the loss of fertility up front. And women with a history of ectopic pregnancy in particular, tubal surgery or pelvic infection carry a higher risk of a future ectopic pregnancy. So just things to keep in mind when counseling the patient. So how does a levonorgestrel IUD work? What are the mechanisms of action? So there are 3 suggested mechanisms of action. The first is alteration of the endometrium by localized exposure to levonorgestrel. The second is thickening of the cervical mucus, preventing passage of the sperm. And third is inhibition of sperm capacitation or survival. So the effects on the endometrium. A lot of you may recognize these words from pathology. I kind of remember them, but in my mind, just generally speaking, it thins the endometrial lining, right? So it's not a very nice place for a fertilized egg to implant itself and carry on into a full-term pregnancy or into advance into further into pregnancy. But you'll see some of the things that the levonorgestrel cause include glandular atrophy, a decrease in glandular and strobal mitosis. All this to say that it thins the endometrial lining, which is why 20% of women end up with amenorrhea at the end of the first year of use with Mirena. The amenorrhea rate for Skyla is 6% at 1 year. This is cervical mucus that's been exposed to levonorgestrel, and it's levonorgestrel 52, so that's the Mirena. And you'll see the sperm that are outside of the cervical mucus but aren't penetrating the cervical mucus. A lot of times we get questions on the effects on ovulation. So is one of the, we've talked about the 3 mechanisms of action: endometrial lining, incapacitation of the sperm, and thickening of the cervical mucus, but we haven't talked about ovulation. So does the levonorgestrel within these IUDs, does it have a huge impact on ovulation, and thus does that impact efficacy? In a 1-year study, approximately 45% of menstrual cycles were ovulatory, and in another study, about 75% of cycles were ovulatory after 4 years, and that was with Mirena. Same thing with Skyla. So a large percentage of women were still ovulating while they had the IUD in place, right? So that tells us that, for the most part, the effects of these levonorgestrel IUDs are localized and not really impacting ovulation. In the clinical studies, women were noted to have ovarian cyst. So in the Mirena studies, about 12% of subjects, and in the Skyla patients, about 13.2% of subjects. Most of these cysts were asymptomatic, although some were accompanied by pelvic pain and dyspareunia. But if you know the baseline rate of ovarian cysts in an ovulatory population of women or in a reproductive age group of women, it's around that range, right? And in these studies, women were having transvaginal ultrasounds to look for things like ovarian cysts or other anomalies that came up during the study. And every time a woman came in, whether she had a functional cyst or any other kind of cyst, it was recorded. So you'll see that reflected here. So in most cases, the ovarian cyst disappeared spontaneously, and persistent ovarian cysts, of course, were evaluated, and surgical intervention was not needed for any of these. So there was a pivotal trial done for Mirena for heavy menstrual bleeding, and thus it has its secondary indication. The efficacy was studied in a open-label, active-control, parallel group trial comparing Mirena to Depo over 6 cycles for the treatment of heavy menstrual bleeding. The primary efficacy variables included absolute change in the mean blood loss from baseline to the end of the study, and then a proportion of women with successful treatment, and they defined successful treatment as less than 80 milliliters of mean blood loss and greater than 50% reduction from baseline. When counseling patients for Mirena, patients should expect that spotting and irregular heavy bleeding will occur in that first 3 to 6 month period, and then shorter, lighter periods will commence thereafter. Cycles may remain irregular and become infrequent, and in 20% of those cases may cease after the first year of use. Some women did not appreciate the irregular bleeding, and even though they were counseled about it up front, were uncomfortable with that bleeding, and there was a discontinuation of about 5% at 1 year. And as I mentioned previously when we were discussing pregnancy and efficacy, if bleeding irregularities do develop after prolonged treatment, after a woman has had a history of this device or this IUD being in place, and then comes back with heavier bleeding, then that should trigger some sort of evaluation. There should be, of course, an appropriate diagnostic measure of the endometrial lining, and then again, consider ectopic pregnancy. So these are the results from the study that we discussed, the heavy menstrual bleeding study. So you'll see the line in black indicates the Depo-Provera injection, and the blue line indicates the bleeding with the Mirena in place. And you'll see that there was an 80% reduction in the median blood loss at 3 months, and a greater than 95% reduction in blood loss at 6 months. So what if a patient, you put in the IUD, and the patient comes in 2 weeks later or 4 weeks later for her checkup, and she's singing your praises because you have stopped her period? And I'm just going to stress the point again that the amenorrhea and the shorter, lighter periods don't occur within that first 3 to 6 month period. They will, in fact, have heavier bleeding and irregular bleeding. Okay. Women can have sexual intercourse right after the device has been in place. There's no need for a backup for any time afterwards. And that all has to do with the timing of placement. And so we'll get to the more specific instructions about timing of placement in just a moment. But essentially, the reason why the timing for placement is the way it is to avoid things like pregnancy. So some of the commonly reported adverse reactions with Skyla include those listed here, and you'll see that increased bleeding is 7.8%. And again, the reason for discontinuation in both Skyla and Mirena studies were this irregular pattern of bleeding. Okay? And again, that's expected within the first 3 to 6 months. the same list here for commonly reported adverse reactions with Mirena, and irregular bleeding and spotting was among the highest reported. So what are some of the serious risks of levonorgestrel IUDs? Embedment and perforation is a risk that's associated with levonorgestrel IUD. Perforation, total or partial, including penetration or embedment into the uterine wall or cervix, may occur during insertion. And so when you have a patient that has an IUD and has had it for a year and comes back for some kind of abdominal pain workup, and you note via imaging or some other modality that she has a perforation, it's highly likely that the perforation occurred at the time of placement and that it didn't just migrate into the wall, of the uterus. The incidence during clinical trials for Skyla and Mirena was less than 0.1% each. If perforation does occur, obviously the IUD is not in the correct location and the mechanism of action won't be at its best. Locate and remove the IUD, and this may require surgery. If there is a perforation, this may lead to migration outside the uterine cavity and cause symptoms like peritonitis or adhesions. There are women who are at increased risk for perforation, and there is a published literature on that, the URAS study. There's a risk of perforation that is increased in lactating women or women with a uterus that is fixed, retroverted, and not completely involuted postpartum. And that is why we give the following direction in our instruction for use about delaying insertion to a minimum of 6 weeks or until involution is complete following a delivery or second trimester abortion. Expulsion is another adverse event or a risk with the levonorgestrel IUDs. Partial or complete expulsion may occur, and this may result in loss of efficacy and put the patient at an increased risk for pregnancy. The expulsion may be asymptomatic or may present as pain or bleeding. So another thing to keep in mind, if your patient has been on the IUD for a year, has had shorter, lighter periods, or even amenorrhea, comes back in and is like, "Doc, I'm bleeding, my periods are heavier, I'm not sure what's going on," it's important to make sure that the IUD is still in place, because that could be a sign of expulsion. The risk of expulsion may be increased when the uterus is not completely involuted, and again, we note in the instruction for use to delay insertion to a minimum of 6 weeks or until there's complete involution. If the device is partially expelled, so if you find that it's in the cervix, it should be removed. And if expulsion has occurred, it may be replaced within 7 days of the menstrual period after pregnancy has been ruled out. In the clinical trials, the rates were 3.2 and 4.9% for Skyla and Mirena, respectively. Any questions? Okay. So pelvic inflammatory disease. IUDs in general have been associated with an increased risk of PID, most likely due to organisms that were introduced during the insertion process, right? Because you're going from the vagina, which is not necessarily a sterile environment, and going up into the upper urogenital tract. So prior to insertion, patients should be informed about the possibility of PID, and that PID can cause tubal damage, leading to ectopic pregnancy and infertility. In clinical trials with other IUDs, not necessarily those that we're presenting about today, and a clinical trial with an IUD similar to Mirena, the highest rate occurred within the first month after insertion, which again speaks to the fact that the PID is most likely being caused by some sort of organism that's being introduced during the insertion process. During the clinical trials for Mirena, I guess I'll just leave this here. During the clinical trials for Mirena, the total combined upper genital infections were reported at 3.5%, and those were even further broken down into endometritis at 2.1% and PID at 0.6%. In Skyla, again, PID occurred more frequently within the first year. So the clinical trials for both Mirena and Skyla reflected what was seen in other clinical trials with IUDs, in that if there is an infection that occurs, it most likely occurs within the first month after IUD insertion, and it occurs because there's an introduction of some organism from the vaginal vault up into the upper urogenital tract. So that kind of concludes our clinical overview part for Mirena and Skyla. So we'll jump into some of the commonly asked questions during counseling. The timing of a levonorgestrel IUD. It should be placed within 7 days of the onset of menses, immediately after a first trimester abortion, right? Because we can be sure in those 2 cases that the patient's not going to be pregnant. 6 weeks postpartum or complete involution of the uterus after you've ruled out pregnancy. The IUD can be replaced with a new one at any time during a cycle without delay. So if a patient comes in and she is at her 5-year mark or at her 3-year mark, and she wants to start a new IUD, you can pull that IUD and replace it immediately. And there's no need for a backup contraception if inserted as directed above. And the patient may resume sexual activity right after insertion. How soon can I get pregnant after removal? So return to fertility with levonorgestrel has been studied, and they found that in the clinical trials with Skyla, 77% of women became pregnant within 1 year of removal, and with Mirena, 80% of women became pregnant within 1 year of removal. And this falls within the range of the fecundity rates in the reproductive age women that were studied in those groups. Will the IUD interfere with intercourse, and can I use a tampon? A lot of women don't really understand sometimes where the IUD will go, and if they'll be able to feel it, or if their partner will be able to feel it. So this question comes up a lot. The IUD should not be felt during intercourse. Sometimes the partner may feel the threads, and their patient might have to come back in and have the threads trimmed a bit. And we'll talk in the hands-on portion and in the insertion training about how long the threads should be after it's been inserted. Tampons may be used with the IUD in place, levonorgestrel IUD in place, without fear of pulling it out or interfering with its efficacy. Can I use the levonorgestrel IUD while breastfeeding? In general, there have been no adverse events that have been found on breastfeeding performance or the health, growth, or development of the infant. However, it's important to note that in isolated post-marketing cases, some women reported decreased milk production. And if you know anything about post-marketing reporting, it's folks calling in and saying, this is what I'm experiencing, and I believe it's being caused by this. Small amounts of the progestin pass into the breast milk of nursing mothers, and the amount of levonorgestrel that is systemically released is on the order of picograms. So that same amount can be seen within the breast milk of a woman who's breastfeeding and is on the levonorgestrel IUD. Clinical trials with levonorgestrel excluded breastfeeding women, and an interim analysis from a large study showed that there's an increased risk of perforation in lactating women, as we discussed previously, and that's that URAS trial that I described. Will it protect from STIs? Can I hear a resounding no? Yes, it will not protect from STIs. And important to counsel patients, especially those that are not in a monogamous relationship both ways, that if they still need to use proper protection to prevent against STIs. Preparations for IUD insertion. So I'll run through the next couple slides, and then we'll watch a video on the insertion process, and then my friends in the back will pass out some hands-on demos for y'all to work on. So patient should be counseled and sign the consent form and the patient information that is provided. Of course, rule out contraindications and pregnancy. Bimanual exam should be done to assess the size and position of the uterus. A speculum exam should be done to rule out any genital contraindications and or cervical contraindications. So we talked about one of the contraindications being like a cervical neoplasia, right? So if you see something that you suspect might be a cervical neoplasia, maybe hold off until that's evaluated before having the patient get her IUD. The cervix should be thoroughly cleansed, as well as the vagina with a suitable antiseptic solution, again, to help decrease that chance that you'll be introducing an organism from the vaginal vault up into the urogenital tract and causing a pelvic infection. The uterus should be sounded and to assess the cavity size and direction, and then the package should be opened. I'm going to skip past these and get to the video. Are you able to play? Yes.
So, long-term cancer risks for breast and cervical uterine, ovarian, and is there any data on adolescents with, I guess, more complications? STIs with the change in the AAT recommendation?
So there is no data from the company, but there is published literature, and it doesn't seem to show that there is a increased risk in the adolescent age group. And if you want, we have a medical science liaison that's also present, and she can provide you with some of that literature if you'd like to address both of those issues. But there doesn't seem to be any increased risk. And your first question was
Cancer risk?
same thing. There doesn't seem to be an association with that. And Cindy is at the back, and she can again provide you with the literature that speaks to that. Okay, so we're going to play the video. I'll ask that you please, watch the video in its entirety before starting to do your hands-on practice with it. We'll have a simulator at the back of the room, outside the doors. It's pretty cool. It's a computer simulator that will simulate the IUD insertion. You'll be able to see yourself inserting the IUD, and then the computer will give you feedback as to how comfortable the patient is with your insertion technique. Okay. And then there will also be further hands-on training out at the Bayer booth that's in the exhibit hall. All right. Any questions? Thank you so much for your attendance and your participation with this hands-on training. I really appreciate you being here. Please let me know or any of my colleagues know if you have any questions. I have a business card I can hand out if you'd like to have my contact information for any future, anything in the future that I can help you with. Thank you again.